Like I remember when I was first diagnosed with PCOS, I thought, oh my God, I'm like a freak. Like I'm like some weirdo who has this weird thing that nobody else has because I never heard of it before. I never heard of anybody who had it. And I think especially as a woman, when you hear about something that, impacts how you look, impacts your fertility, it can feel really kind of scary to be branded with this thing. We've had just a lot more awareness just from people sharing their own stories. So, celebrities speaking about having these conditions, patients talking more openly about it. I think that's actually been a game changer, just awareness growing that I think we've needed.
It is a very heterogeneous disorder that probably is multiple different disorders that kind of all end up sort of looking the same, but may have different origins. And quite honestly, often does look very different in different patients. Sometimes patients who are lean with PCOS will be told, oh, well, you couldn't possibly have PCOS because you're lean. And so that's a sort of a myth that kind of gets perpetuated out there that then leads to patients feeling like they're not being heard. Or sometimes conversely, patients will maybe have PCOS but be told, oh, well, it's just your weight. You just need to lose weight and you'll be able to fix this, which I think is also a really damaging kind of idea for patients to take on.
Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Welcome to the Golden Hour. I'm your host, Dr. O, and today I'm joined by two women who are transforming care for some of the most overlooked conditions in women's health, PCOS and endometriosis. First, Rachel Blank, founder and CEO of Allara, who's created a platform after her own struggle to get a diagnosis and compassionate treatment for PCOS. Allara now connects women across the country with OBGYNs, endocrinologists, and dietitians who treat the conditions from whole health root cause perspective. Before Allara, Rachel led strategy at Roe and graduated from Harvard Business School. Alongside of her is Heather Huddleston, one of the nation's leading reproductive endocrinologists. She directs the UCSF PCOS Clinic and research program, and her work in PCOS, recurrent pregnancy loss, and complex uterine disorders is widely published and nationally recognized. She brings decades of clinical and scientific experience and expertise to the Allara model. And together, they are building what PCOS and endometriosis care should and will look like, with evidence-based, personalized, and actually accessible care. And today we get to talk to them about everything endometriosis and PCOS. So welcome, Rachel. Welcome, Heather. I'm so excited for this conversation.
So thanks for having us.
Yeah, great to be here.
I already shared, Heather and I have a connection, not only in terms of my training at UCSF, but more importantly, the floods of patients I've sent her way. I feel so grateful having fertility specialists like you locally to take great care of my patients. And Rachel, we too have a connection. I actually first heard of Allara from a patient who was so grateful for that additional care. For me as an OBGYN, despite my excellent training at UCSF, PCOS and endometriosis feel like conditions that I understand in terms of pathophysiology, and I understand in terms of the kind of standard algorithms of care in terms of workup and management. But I feel like there are so many nuances beyond that. And what I appreciated about talking with this patient, and what I appreciate about what I know is going to happen in this next hour of our conversation is learning from your perspective, Rachel and Heather, about the nuances of PCOS and endometriosis care. So thank you in advance for what's going to be a very fruitful educational conversation.
Thank you. That's really nice to hear.
Yeah. Well, Rachel, let's start with you. Your origin story, if you will, is not unique in that most of us kind of find ourselves pulled by something that is personally and deeply connected to us. So if you don't mind, can you kind of share your origin story? What led you to found Allara? What was your personal experience that made you feel like there definitely could be a better care experience for patients like me?
Yeah, sure. So I was diagnosed with PCOS about 15 years ago, really actually kind of as a fluke. I was investigating a lot of GI issues that I had. And as part of all these workups I was getting, actually somebody doing an ultrasound said, "Did you know that you have PCOS?" And I said, I have no idea what that is. What are you talking
Yeah.
about?
Yeah.
And he said, well, your ovaries look like textbook PCOS ovaries. And it really kind of actually explained a lot of things that, I had experienced the prior 5 years. I was getting my period once a year. I gained a ton of weight when I went to college. All of
Mm,
these things that I just almost didn't think to question, but then just really started to add up. And then I would say, once I got that diagnosis, what was kind of shocking and frustrating was how hard it was to actually then get care for my condition. So to
mm,
go to a place of, okay, well, where do I go? Who's a specialist who can treat me in this? It felt like that didn't really exist. And then the other piece of my origin story actually is my dad is actually an OBGYN. So I grew up
cool.
around, yeah, I grew up around women's healthcare. And I always, by the way, historically have had this very positive view of it, right? Like we would go out to dinner
Yeah.
and we are just accosted by my dad's patients, being like, oh, this is, Timmy who you delivered. This is John who you delivered. Like this man is the mayor of DC. So I just really was so incongruent to me. Like, well, how can all those patients be having this incredible experience? And
Mm,
yet I felt so frustrated. And luckily, because I was able to see, what does it look like to be a practicing OBGYN these days, I was able to understand that, it wasn't that providers didn't want to provide better care for these types of patients. It's that, when you're seeing 6, 7 patients an hour, you're oftentimes their primary care provider. You don't necessarily have time to then dive in to the
yeah.
complexities of a chronic condition. And so
Yeah.
it really felt to me like almost it was more of a format issue. How do we give these providers a
Mm.
different place and format to practice in where they can spend more time, where they can dive in to these more complex care needs? And that was kind of the genesis of Allara, was using telemedicine to give providers more time with their patients to be able to really dive into these more complex care conditions.
Yeah. So beautifully shared. One of the things I love about living and practicing in the East Bay is that, yeah, I can be on a walk with my husband or running an errand, and mind you, who I am in clinic, it's very different from like weekend Hana where I'm like in sweats and there's no makeup. And so sometimes I run into those same patients and their beautiful families. I'm like, no, not now. Don't look at me. But you're so invested in that community, and you feel so emotionally tied to their experience and to making sure and ensuring that they're having great outcomes. And yet I always feel this internal conflict as an OBGYN where, as you said, we're seeing so many patients in an hour. And when I'm coming off of a 24-hour shift yesterday of overnight call plus a clinic with 20 plus patients and everything else in between, and you're just running and you're in a system that forces you to keep sprinting to the finish line, which means that 20-minute, 15-minute, 10-minute appointment doesn't feel like sufficient to cover something that's been a lifelong experience for a patient, something that impacts so many different aspects of their life. And so my origin story is a lot of that frustration I felt with this healthcare system that truly did limit my ability to have meaningful, kind of deeper conversations with patients, really pushed me to create a podcast where I can, spend an hour plus talking about these topics. And so I feel a lot of gratitude to have this moment to advocate for those patients who I care for deeply, knowing that I can't necessarily do it all in the 20-minute appointments I have. Heather, let's transition to the medical side. So you have so much experience, not only as medical director or chief medical officer of Allara Health, but also, director of the PCOS clinic at UCSF. From your perspective, where do you feel like the gaps of care are in terms of PCOS care and management?
Yeah, I mean, I think there's a lot of studies that have been done sort of looking at this question of how do patients with PCOS feel about their journey. And there's been a study done internationally, actually. There was a study actually that Rachel and I did together looking in the United States, but really just capturing this idea that broadly speaking, people with PCOS feel like it takes a long time to get a diagnosis. It takes a long time to find providers that can sit with them and really help them understand all of these intersecting issues that are going on reproductively or metabolically. And so I think that there's sort of been a long-standing gap for that patient population. And I
Mm,
think part of it is, what Rachel was talking about in terms of the provider type OBGYNs who are, I think, great at sort of understanding PCOS and connecting with patients, don't necessarily always have time I also think there's some other trends in the system. So reproductive endocrinologists, I think also are really well trained to understand PCOS.
Yeah.
But more and more, we are really just inundated with fertility. That has become just a huge part of what REI is.
Yeah.
And a lot of times people will say the I has sort of taken over the E. There's just way more
Wow. Yeah.
infertility than endocrine. And so that
Yeah.
provider type has really kind of almost been taken out of the mix as someone who can really delve into these issues with our patients. So I do think this patient group has fallen through the cracks in a lot of
Mm,
places. PCOS Clinic at UCSF was really meant to address that when that was started about 20 years ago, where we wanted to
mm,
also say PCOS really does have a lot of different issues that come together, like you
mm,
said. And so, can we bring together some more provider types? So, can we have a reproductive endocrinologist as well as a nutritionist? Can we have
mm,
even a psychologist coming in and being able to sort of take all of those issues the patient's having and sort of tackle them all at once. And I think that model's worked great. I do know that our patients generally feel so heard when they feel like they've been able to
mm.
come in and know that someone understands their condition and is able to look at it from several different angles. And so when Rachel was founding Allara and spoke to me about what she was envisioning, to me it really was inspiring, this idea that maybe some of the things that we were trying to do in our little small clinic that could only reach a very small number of patients, bringing
Yeah.
that out to more people, really throughout the country and giving that expanded access to this idea.
Yeah. That's beautiful. I mean, when I hear your description of this multidisciplinary team that you guys had developed in, yeah, the small niche of the UCSF PCOS clinic and then seeing it expand to such a larger reach with Allara, that's the dream. That's hashtag goals as the youth say, right? To be able to bring that idea into fruition. And hearing you, I think of the tension that I have as an OB/GYN where patients of mine who don't know about the UCSF PCOS clinic who live here locally, or patients who otherwise haven't had the opportunity to experience care with Allara, they look to me to be the OB/GYN, the endocrinologist, the dietitian, and their mental health provider. And again, in 20 minutes, I can't do that. And so I think I sometimes walk away from my clinic days feeling frustrated and defeated. But one of the things I appreciate the most about this podcast experience is because I get to talk to people like you, Heather, and Rachel, who give me hope, who give me that sense of like, no, 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 I'm not in this alone. Like, I don't have to put this all on my shoulders. I can place referrals. I can make recommendations to amazing programs like Allara. It really feels like I can actually really meet my patients where they are. Um, and so as we talk more and more about PCOS, it's an incredibly common condition, and yet it tends to be misunderstood. If you guys could rewrite the definition of PCOS, would it be?
Like Heather, aren't you working on this, Heather, a little
I
bit?
can, I mean,
Yeah.
it's interesting. I think PCOS, I think we've made it hard for ourselves. We've made it hard for our patients over the years with how it's been defined. It is a very heterogeneous disorder that probably is multiple different disorders that kind of all
Mhm.
end up sort of looking the same, but may have different origins. And quite honestly, often does look very different in different patients. And so I think that has been part of what's led to confusion.
Mhm.
And so I know sometimes patients who are lean with PCOS will be told, oh, well, you couldn't possibly have PCOS because you're lean. And so that's
Mhm.
a sort of a myth that kind of gets perpetuated out there that then
Mhm.
leads to patients feeling like they're not being heard. Or sometimes conversely, patients will maybe have PCOS, but be told, oh, well, it's just your weight. You just need to lose weight and you'll be able to fix this,
Mm.
which I think is also a really damaging kind of idea for patients to take on. So I do think it is a complex disorder. We don't really understand where it comes from. I mean, there's lots of research going on into this. Is it the underlying insulin resistance that starts first? Is it the hyperandrogenism being driven by the pituitary that starts first?
Mhm.
There's now a lot of really interesting research going on to the in utero environment and how that
Yep.
might contribute to the evolution of PCOS in patients. So there's a lot of theories, but of course we don't really know that. We don't have great explanations where we can just say, so for example, take hypothyroidism. I think when someone has hypothyroidism, you can kind of say, here's what's going on. You probably have these antibodies, they're hurting the thyroid, you've got your TSH goes up, and It's fairly clear, we
Yeah.
can kind of explain that to the patient. With PCOS, it's so much harder. It's such a complex disorder. There's multiple things going on. And so it kind of is what it is. I mean, and this is what I have to tell my patients is that this is complex. We don't understand everything. We're doing our best, but for you, let's figure out what are your main symptoms and
Mm-hmm.
how can we tackle those? We're
Mm-hmm.
not trying to solve the entire PCOS mystery when we're sitting down with a patient. We're really just trying to make them feel better. And
Yeah.
so I think for me, that tends to be a guiding sort of star for me when I'm seeing patients is it honestly doesn't even really matter whether
Yeah.
you fall into this criteria or not, but we really want to understand what's your metabolic health, what's your reproductive health, what are the symptoms, how can we make sure that you stay healthy throughout your lifespan, how can we make sure that you're not suffering from symptoms that are, that we have medications to treat.
Yeah. No, I mean, I could think of the patient who, as you shared, has been dismissed because either she didn't necessarily fit like a classic phenotype or was told otherwise that their primary issues are around their weight. And so by the time they either find Alara or see you, Dr. Huddleston, they probably feel pretty defeated and deflated. And so if it, in an odd way, being told like, actually, this is a really complex condition. And even the smartest of us, the best researchers are still making a way through this, but this is what we have to help you. I think for me, I can imagine this like moment of being like, yes, this is not all in my head. This is confusing for me as a person experiencing it. And there are a lot of different ways, a lot of different kind of tackle the multiple body systems and multiple things that are affecting me. Rachel,
Yes.
not only as the founder, let alone a patient who experienced PCOS herself, what was your approach to create Allara in terms of helping patients kind of map that complexity of their
Mhm.
care?
Yeah. So a couple things. I mean, one, I knew I needed, some of the experts in the field.
Yeah.
That's why I'm so thankful I was connected to Heather early in the journey, and she really helped us think through the care protocols and how to approach this. But I say something that actually was really core to me in the vision of Allara was to build a multidisciplinary care team. I think
Mhm.
something that I actually found frustrating as a patient was because I didn't always feel supported in the medical community. I was spending a lot of time on like Reddit and Instagram and found these very different opinions. Like it kind of felt like there was the medical authorities who would say, like,
Mhm.
these are the medications you can take and not speak about nutrition and lifestyle because that's not their
Mhm.
domain. And then the nutrition and lifestyle experts would say, well, don't even talk to a doctor and don't let them put you on birth control and just approach this all naturally. And there was no place that it felt like you can really go to kind of bring them both into one place, right? To be able to bring
Yeah.
the best of like Western medicine and medication. And I know birth control gets a bad rap, but I love birth control for
Me
myself.
too.
And bring all that with like diet and nutrition protocols. That was always really core to the ethos of Alara was from day one, we've had patients paired not only with medical providers who can do extensive lab work, who can manage medications for them, but they're also paired with registered dietitians who can
Mhm.
really manage, lifestyle and diet for them and help really supercharge their outcomes. And I think the other thing that was really core to me was to make sure we were looking at these women's health conditions not just from a reproductive health lens, but from a whole body
Mm.
lens. So,
Yeah.
when you're a patient at Alara, we're not just texting your sex hormones and we're not just talking about can you get pregnant or not. That's a piece of it. But we're also, looking at your metabolic health, looking at your cholesterol, looking at are
Mhm.
you insulin resistant or pre-diabetic and how does it kind of all fit together and taking a much more, I'd say, holistic view of your health.
Yeah. Yeah. No, I mean, that's amazing. I think, I mean, my brain is thinking about all the PCOS patients I saw this week. I'm like, okay, well, I guess I'm going to send them a My Health Online message with the website link to
Yeah,
Alara. But
good.
it's because there is just so much to offer when you take one clinician, little old OB/GYN like me versus being able to have access to all of that lab work, to
Hmm.
all those
Yeah.
experts, right? Like why should we be limiting patient care? I think, a question I like to ask both of you is for me as an OB/GYN and for any OB/GYNs who are listening who are, yeah, we're in our practices, we're seeing patients for these PCOS consults sent by our PCP colleagues. What can we do in our capacity as clinicians and how can we be better to show up for our PCOS patients?
I mean, I think almost all OBGYNs are, out there just fighting such a good fight on multiple fronts with so many important conditions that women are struggling with and amazing times in their life and challenging times in their life. And I've never regretted being in this field of women's health. So I would say what's interesting, well, I guess what I want to throw out there is that most of the patients at Allara also have an OBGYN or a primary
Mm-hmm.
care doctor, and we encourage that. We are telemedicine and we have an important role to play, but we're not ever going to replace the in-person OBGYN. And
Yeah.
so I think that's an important message to say, keep doing what you're doing, keep trying to show up for your patients, but recognizing you only have 20 minutes. And maybe if that patient does need more time, there are ways to get that patient that
Mm-hmm.
time and those resources. And I think another thing that Alara is really set up to do well, in addition to this multidisciplinary approach, is to be able to see patients a little more frequently. And so
Mm-hmm.
that's something even in our PCOS clinic at UCSF, we don't do very well. I mean, we're not set up for longitudinal care. We're really set up as a consult. We see them once, we give them lots of information, but then we send them on their way. And
Yeah.
these patients often need that a little more help, especially in the beginning, and they need a little more frequent touch points to sort of say, well, we started this medication, how's it really going? Or maybe we need to change that medication. Or we've talked about these interventions we want to do for your lifestyle. We talked about an exercise goal. Are you making that goal? How can we help you with that? And so some of that needs to evolve over time. It's not a one
Yeah.
visit situation. And so just knowing that there are now these places like Alara where I think patients can, maybe you meet with them first and give them great information, but
Yeah.
if they need a little more handholding over the next 6 months as they kind of go through their journey, I think Alara is set up to do that really well.
Yeah. Yeah. I mean, I always love the concept of collaborative care models in whatever way that it looks. On labor and delivery, it's the midwives and the doctors working together in ambulatory practice. It's the OBGYNs and the APCs that are on the ground working with companies like Allara. Like, I really do think it's not an us versus them. It's like a true
Right.
synergy. And so for that
Yes.
patient who came and saw me and was the one who name dropped Allara, now who knows how long ago, it was this idea of like, oh, okay, great. Like, I'm so glad you found that resource because you're right. In my 20-minute appointment, and honestly, by the time my MA rooms you, it's like a 10-minute appointment. I will not be able to cover that. But I'm so glad that you learned what you learned from them. Like, let's see what I can do in terms of lab work or prescriptions. And I think one of the things that I also recognize is a weakness of mine, and I hope any other OBGYN listening will be honest in that as great as our training is, we don't learn nearly enough about nutrition. And whether it's with PCOS or fertility journeys or anything in the realm of women's health, nutrition is paramount. It is foundational to so many things that we experience: perimenopausal care, menopausal care, right? The whole life spectrum. For me to have like a quick, like, top bullet point rundown of nutritional health and support for PCOS patients, what would be kind of top pieces of advice that I can tell a patient who's seen me, yeah, only in 10 minutes, but I can kind of share them. Here are some highlights. Before I send you off to Laura, here are some highlights that we should talk about. What are ways that I can be empowered as a clinician in terms of my nutritional information?
Such a tough one because I think it really depends. It's so variable depending on the
Yeah.
patient and what their particular situation is and where they're coming from. And I think one other little piece of information that I want to just give space for is that we do know also a lot of our patients with PCOS have disordered eating or
Mm,
struggles in that way that sometimes I wonder some of it may be caused by us as clinicians or caused by us as a
yeah.
society, putting so much pressure on this patient population to fix themselves
Mhm.
and getting all that messaging can be really hard, I think, on this patient
Yeah.
population. So I think that's where 10 minutes is not really enough time to
No.
start delving into where is this patient? What is their history around dieting and eating? What are their goals? What do they feel capable of doing right now? So it's a little bit mission impossible to accomplish
Yeah,
that, I think, in your 10-minute visit. But I
exactly.
I think what our team is doing is really trying to help, first of all, diagnose and clarify what a patient's metabolic status is. And some of our patients metabolically may be pretty healthy. Some of them may have diabetes or prediabetes. And so
Hmm.
those are going to take really different approaches. And I think the collaboration between the medical provider and the nutritionist is really powerful because sometimes medications are really going to be helpful for these patients. We have incredibly powerful new medications available in the form of GLPs, which I think some of our patients
Yeah.
really can be life-changing, or metformin. But the lifestyle piece is going to be important whether or not we're adding medications. And that's
Hmm.
where finding out what I think, to me, the starting point, and I'm not an RD, we have amazing RDs on our team, but I think the starting point is figuring out where they're at now. What are you eating now? What does your diet look like? And then taking it from there. Because starting points are often just trying to work on having more whole foods, less processed foods, looking at mindful eating, looking at how, snacking, and those types of issues that can really undermine people's progress. So, again, I'm not the nutritionist on the team, and so I'm probably not doing justice to what their work is, but I think it ultimately is very individual. And
Yeah.
that's where having an hour visit with a nutritionist is
Yeah.
so important, right? Because it's such an important part of our life, eating, and there's so many social, emotional factors that go into that you really need that time to really come up with a plan for a patient, I think.
Yeah, yeah, no, it's a multi-pronged approach, and that 10-minute those 10 minutes I have will never do it justice by any means. So I think it's a good reminder for us clinicians who are listening to these to this episode to think about how we're approaching our PCOS patients, how we're scheduling follow-up with them, if we feel like we need to kind of keep that onus on ourselves, or simply I'm just whispering it to my friends, just send them to Allara. It's easier that way.
Yeah,
Rachel,
well, and then
go ahead.
no, I was just
No,
gonna
no,
say these
please.
things are. I was just gonna say lifestyle changes are hard. We did a study with our own PCOS population that had come into our clinic and looked at two different exercise interventions that we had them do. And at the end of the study, really the take home was that nobody really did the exercise and no one really improved. But the reason was basically all we did was say, hey, you need to exercise, here's what we're going to tell you to do. And then we checked in with them 3 months later. There was no coaching, there was no checking in, there was
Mm,
no support. And so my take home from that is clinicians just telling a patient like, hey, go eat better and exercise is really, it's just not enough. I mean, that's
yeah,
not what is going to get the job done. And that's not the doctor's fault. These are just hard changes to make. So just knowing that, finding resources, finding places where people can get a little more of that coaching along the
yeah,
way help them feel supported, because these are hard changes to make.
yeah. I think of any health coach as like an accountability buddy, right? Someone who's going to say, "Hey, like, did you do the thing that you said you were going to set out to do?" No, I appreciate that reminder. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so it can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Rachel, as we transition to one of the other kind of big topics that Allara approaches, endometriosis, that's something that so many women suffer in silence before they even get the care that they need. Why do you feel like, from your research, from the team of incredible clinicians that you've probably brought together to help build Allara, why do you think it's still so hard for people to get answers?
Yeah. And I mean, sadly, it's true across all these conditions, right? Like
Yeah.
endometriosis, it can take 10 years to get a diagnosis. PCOS, we've done multiple studies. It can take multiple years. I think a couple things. I think actually I think one piece is actually just we've kept ourselves silent in a lot of ways. So I think up
Hmm.
until a few years ago, actually, it didn't feel like people were really talking about having these conditions, right? Like, I remember when I was first diagnosed with PCOS, I thought, "Oh my god, I'm like a freak. Like, I'm like some
Oh,
weirdo who has this weird thing that nobody else has because I never heard of it before. I never heard of anybody
Yeah.
who had it. And I think especially as a woman, when you hear about something that, impacts how you look, impacts your fertility, it can feel really kind of scary to be branded with this thing.
Mhm.
And I think really luckily, especially with, a lot of those conversations happening on social media, we've had just a lot more awareness just from people sharing their own stories. So, celebrities speaking about having these conditions, patients talking more openly about it. I think that's actually been a game changer just in terms of allowing you as a patient to say, like, oh, okay, these symptoms that she talked about that ended up being endometriosis, I actually have those symptoms. And so it's kind of like
Yeah.
this awareness growing that I think we've needed. And I think also, as both of you know too well, we have so little research being done on these conditions.
Mhm.
I think the fact that with endometriosis, for example, we can still only really diagnose it with surgery is pretty
mm,
terrible.
Yeah.
So I think it's a mix of both. Okay, awareness needs to grow, which has been great. And I think it has been growing, but also, how do we really get more research and better interventions for these conditions that I think we're really still working on in a lot of ways. But yeah, I think that's why I think part of what we do at Alarm, and part of what we think our mission is to educate patients, is to use,
Yeah.
our Instagram, our TikTok, emails, not just to talk about our care, but to talk about these are common conditions. These are common symptoms of these conditions. If you feel like something's off, go advocate with your doctor. If you feel like you're not getting the tests you want run, maybe go to a different doctor. Like, really about kind of educating and empowering patients. We really view as a really crucial part of our mission because of exactly what you said, because it's still these are still such underdiagnosed conditions.
Yeah. No, I mean, I'm giving you a virtual hug, Rachel, even though I know you don't need it. Because when I think about, like you said, when you initially got that diagnosis of PCOS, you felt like in that moment so isolated and so othered, right? And maybe a
Yeah.
little bit of shame because at that time, before you founded Alara and probably made these conditions more of a talk of the town, it was kind of this like something I think a lot of people kind of kept silently to themselves.
Hmm.
I think I think social media is a double-edged sword, right?
Yeah.
All of us here know that, right? And that one of the beautiful aspects of social media is it does create community. It creates conversation. I think it's for a lot of women's health conditions, PCOS, endometriosis, perimenopause. It's now part of like the common conversations. My Instagram algorithm knows I'm an OBGYN, so I'm constantly getting reels that I think are. It's great that my patients are seeing, right? It's great because that they give them it gives them an opportunity to say, oh, I think I'm experiencing these same things too. Like, let me go find Dr. O and talk to her about it. And I think also on that same, like kind of other end of the double-edged sword, if you will, social media also has its potential harms too.
Hmm.
I jokingly say sometimes that my arch nemeses are nurse TikTok and Dr. Google because you're also finding things. People are trying their best, but they're finding things that aren't necessarily vetted either. I think you alluded to that, Rachel, with your early Reddit deep dives, right? So, Heather, when you think as a clinician, when you think of the patient who was recently diagnosed with endometriosis, what are the first steps that you think that they should?
well, I think, if they do you mean like they've been diagnosed surgically, so they had
I know.
surgery and
Yeah, exactly. Thank you. As I asked you that question, I was like, that is actually the perfect counter. I would say because, as you know, Heather, most of our patients were not necessarily diagnosing with laparoscopy, right? We're taking their history and saying, okay, it's most likely this, it's most likely endometriosis. Let's treat. And please, this is why I'm having this conversation. So please let me know if there's any I should change my practice. I will gladly do
Yeah.
so. I generally reserve laparoscopy for my patients whose symptoms are refractory, so not responding to
Yes.
medications.
Yes.
What's your approach?
Yeah, I mean, I think that's right, and I think a patient who we think is either at risk for endometriosis based on symptoms, or perhaps they've had a ultrasound that shows an endometrioma or something like that. So we have strong clinical suspicion around endometriosis being the cause of their symptoms. I think for sure you want to ideally leave the surgery as sort of a final pathway. if the other treatments aren't working. And so, working with the patient to understand what the available treatments are. And, certainly that's where oral contraceptives can be very, very helpful. Taking them continuously can be very helpful, but other strategies as well. And that's where even thinking about sort of lifestyle things can sometimes
Yeah.
be helpful. And I think we're learning more about dietary triggers for inflammation and how can exercise help with this. So again, that sort of multidisciplinary approach can also be really helpful.
Yeah. I know you are not a dietitian, but from the research that Rachel has pointed out is quite limited. What are specific dietary triggers? What are some of the top food items that people should try to avoid if they have endometriosis?
Well, I don't know that there's one sort of food item that, or sort of, and I don't think the research is that great to sort of, from an evidence-based standpoint, say anyone with endometriosis should avoid X, Y, or Z. I don't think we know
Yeah.
that, but I think helping people understand that they can really listen to their body and
Mm,
understand how certain types of diets or certain patterns, lifestyle patterns, may be not help helping them feel better.
okay.
And so, I think there's a strong connection in a lot of my patients with endometriosis with other GI issues.
Uh-huh.
So sometimes I'll sort of try to get to the bottom of that a little bit of like, are there certain times you notice your GI issues flaring up around the endometriosis? And then
Mm,
can we sort of link that to anything that you're doing dietary wise? And that's where maybe thinking with a nutritionist about, you know, should I have a trial of, lactose-free week or something like that to see if
yeah.
that's, flaring things up. So, I think it's there's a lot for us to understand there, but I do think that there's ways within just the lifestyle arena to also help with endometriosis.
Yeah. And Rachel, you already alluded to, when it comes to women's health in general, sadly, but PCOS and endometriosis, there's not much research. Why do you guys think that is? I know that's a really hard question to answer, but you're in it. You're at the table. You're talking with a lot of, women's health innovators, advocates, thought leaders. Why are we still so lacking in what seems so like such an
Yeah.
obvious
I mean,
approach?
part of it is funding. So
Mhm.
there's very limited funding that is going to women's health research. If you look at, like, for example, NIH budgets around women's health conditions, I think PCOS and endometriosis got like $10 million, maybe $20 million to study, versus you look at conditions that affect less people that are getting hundreds of millions of dollars to study. So
Mhm.
part of it is just access to funding. And, that's true also, by the way, in the startup community, right? Like,
Yep.
if you are a female founder working on a women, especially working on women's health, it's improved, but the access to funding even to start more innovative companies is limited as well. So I think that's been just a big blocker. I think
Mhm.
also, something I've noticed has been really interesting is kind of explaining to people and having people understand why this is not just a reproductive health issue. I think
Mhm.
sometimes, especially when I first started fundraising 5 years ago, I would hear things like, well, isn't this really niche? Like, isn't this just like this niche thing? I'm like, nope, very common conditions.
Yeah.
Or like, well, why does it really matter? Isn't it just your period? And it's like, nope, here's how it affects every single part of your body. And so I think this has improved a lot actually over the past few years, but I think actually just again, the awareness of the commonality of these conditions and that they're not these niche small conditions. I think in some ways, like the silence around them has actually kept a lot of the research from happening, because if you don't think it's
Mhm.
a big pain point, then why would you go fund a bunch of research
Mm,
into them?
Yeah.
that's an interesting thought. Yeah.
Yeah, Heather,
I
did
think
you
it's
have a
yeah, I
follow-up?
mean,
Yeah.
I think it's really a mystery exactly why women's health conditions have been so poorly funded
Mhm.
over the years. And but the statistics are really astounding around the amount of money that goes to women's health conditions compared, within the overall budget
Mhm.
at NIH. So I think we need to keep advocating. I think
Yeah.
we need to just keep making it, clear that this isn't acceptable. But I also think, finding other ways to get some of this research done is also a possibility, right? So maybe the private sector can sort of step up and start really pushing forward some ideas or some strategies. And that's where I think the more women stand up and say, this is something that we want, I think you'll see more of that happening.
Yeah.
But I mean, there's certain conditions that we treat, and I'm sure you know this, that I feel like we're still a little bit in the dark ages with what we're
Yeah.
doing, and compared to, my husband is an orthopedic surgeon, and I feel like that field is so highly technical. They've got robots doing everything,
Yeah.
and they've got, a lot of investment from research and also in the private sector. And so why is that not happening as much for women's health?
Yeah. Yeah, no, I totally agree. I mean, I think that unfortunately women in terms of our society have unfortunately like been um not necessarily second class citizens. That feels so dramatic, but yeah, there's just a tendency to kind of push our concerns to the side. I mean, I think about even small things. My sister's a urologist. I think about small things where whoever decided how we get reimbursed for doing a procedure, so she'll do this a
Mm,
cystoscopy and get reimbursed more for that same cystoscopy if I do it, right? It's the same exact procedure. We're just
aw.
putting a camera inside the
Huh.
bladder, but somehow my sister, because she's a urologist, will get more money for that same procedure. So there's something about how we value women, right? There's something about how we value women and our role in society and the way that health affects us. And that is a deep, deep conversation for maybe a couple more hours and a couple bottles of wine. But yeah, no, I appreciate both of your insights there. As we think about PCOS and endometriosis as it affects fertility, I appreciate what you both have brought up multiple times, is that it's more than just fertility care. It's the whole body system, the whole person. But, oftentimes those patients are reaching like a branch point if they do choose to have families where their conditions are impacting the ability to start those families. What do you wish people knew more about fertility in relation to endometriosis and PCOS?
Well, one thing I would say about PCOS is that what I wish more people knew, especially as and hopefully awareness is improving, but especially as people are coming through their teen years and maybe getting diagnosed for the first time, is that this is a very treatable condition from the
Mhm.
standpoint of fertility. I can't tell you how many patients I've had come in and see me and tell me, like, well, I've been told I can't have kids. And
Mm.
maybe that's not what they were told, but somehow that's what they heard.
Yeah.
And they really think fertility is gonna be this just incredibly difficult thing for them to achieve, and I think that's a hard burden to be carrying, through your teens and your 20s, thinking like somehow I'm already damaged. I'm not going to be able to have kids or it's going to be this big problem. And so, what I try to spend a lot of time doing with my patients with PCOS is really just explaining, like, first of all, number one, you've got a lot of eggs. That's one of the reasons that your ovaries look like this. It's maybe one of the reasons your hormones are a little out of whack, but you've got beautiful ovaries with lots of eggs, and that's important, and that's step number 1 in getting pregnant, and you have that.
Mm.
And that it's not really an infertility diagnosis in as much as is just you might have trouble with ovulating, and we have ways to help that.
Yeah.
And so, really just trying to take that concern down a notch a little bit for our patients so that they can kind of move forward with their life feeling a little more calm and that we've got this and we can really
Mhm.
help them. So I think that's important from the PCOS side. I think the endometriosis side is hard. I mean, we don't always know how much their fertility is going to be impacted
Yeah.
until they really get started trying. I think really, for both of those groups, I would just say making sure that you seek care earlier than later so
Mhm.
that you're not spinning your wheels for years and then finding out, this is maybe what's going on and we have a way to fix it. And just knowing that there's providers out there everywhere who are ready to sort of try to tackle these things and so that they're not alone.
Yeah. Yeah. No, I appreciate that perspective. When I think about the patients who I see for preconception visits, and there's so many times in those preconception visits that everything seems fine, quote unquote, right? But do you think that there's a role for me, OBGYN, and those out there, if a patient shares, in that history that, oh yeah, I've always had painful periods. I was managing it with birth control pills. I'm off now because I'm ready to get pregnant. Is that a patient who we we should say, "Hey, that might mean that you have endometriosis. If you try for a couple months, circle back with me." Is there a chance for us to kind of intervene sooner?
Yeah. Yeah. I think so. I mean, I think that's a great approach. The way you're describing that is to just say, you know, I don't want to over medicalize things and send
Yeah.
people to fertility treatment when maybe they don't have maybe they're going to get pregnant naturally the first time they
Yeah.
try, right? So we don't know.
Yeah.
But I think giving people that sort of time frame is often really helpful to say, I want you to go try, but after 6 months, I really want you to come back, or after 3 months. And, I have a little concern about this, but I still think you should try on your own. But if it's not happening quickly, there's things that we can do. And I think
Yeah.
that's a great approach.
Yeah.
Yeah.
Okay.
I think the other thing that could be really helpful, just something I've seen, is actually encouraging patients, if you know you have this condition, like to start thinking about it before you start trying. So, for
Mm.
example, I've always had super regular periods. And so, actually, even before I started trying, I started working with my Allara provider on just getting my periods more regular so that I actually had a shot at getting
Yeah.
pregnant naturally.
Yeah.
Like, I went on metformin, that made a huge impact. So I think actually just telling people, like, there's actually things you can do before you even start trying can also be really, really helpful to a patient.
Yeah,
Mhm.
and we all love control. I'm a type A person.
Yeah,
I love that
same.
feeling, that locus of control. And so there is, I think what makes that fertility journey and let alone pregnancy and postpartum so difficult sometimes is suddenly that locus of control really gets out of your hands. But I love that, Rachel. I love the idea of like, no, I can actually be proactive. I can be, even infertility preventative, if you will, in terms of
Yeah.
trying to kind of really approach this as actively as I can ahead of time. What were some of the strategies? It sounds like you said that, metformin really helped you in your own personal journey. What are some of the other strategies that you, share with
Yeah.
clients or you think about for
Yeah,
PCOS
so I think
patients?
one is, again, understanding what's going on. Like, I nobody had tested my insulin levels until I started
Mm,
Allara and met with a provider there because I'm lean. So my whole life, everybody said, "Well, we won't even look at it." And it turns out I did have insulin resistance, and so metformin
yeah,
was hugely helpful. So I think one, actually just doing the testing is really valuable. Medications like metformin. For me also, diet, I think, played a big role, like really focusing on high protein, not eating. I know our RDs have this concept of like, don't eat naked carbs.
uh,
So like, have carbs, you should still have them, but try to add like a fat and a protein so that they're not naked and you're kind of regulating your blood sugar a little bit better. That concept has been really helpful. Yes, those are a few things top of mind.
yeah, yeah. I like that.
I think
Um,
another thing
Go
I'm
ahead.
seeing is more patients, which I think is a good trend, is there are more patients coming in a little earlier saying, I just want to understand my fertility a little bit. I want to maybe make sure I'm healthy before pregnancy.
Mhm.
And I think that's something, that sort of idea of like preconception optimization is something that to me is I'd like to see that trend grow, right? Because I think
Yeah,
the more we can have people maybe understand their health, maybe optimize a few things ahead of time before getting pregnant, I think we'll have healthier pregnancies.
yeah,
And so I think that's a trend I'm starting to see. I think it's something I'd love to see grow over
yeah,
time.
yeah. For Heather, for the patients who are listening, who are prepping to go see their OBs for like their preconception visit, what are some of the top categories that you would say that would help them feel empowered going into preconception optimization?
Yeah, well, I think, that there's some really basic things that are now recommended for
Yeah,
preconception testing. So things like making sure you're immune to rubella and varicella, there's carrier screening now
yeah,
that's ACOG is recommending. So that's where you're checking both you and your partner to make sure you don't overlap on any genes that could be a problem. So some of that basic testing that's just like
hmm,
making sure you're ready to be pregnant. But I think for a lot of people, also looking at things like, are you metabolically healthy?
hmm,
What's your BMI? If you're in a range where maybe it would be helpful for that to be a little bit lower to optimize the health of your pregnancy, is that something you want to work on before
yeah,
you get pregnant? And may also help you get pregnant more easily. So
yeah,
I think sometimes those metabolic things are worth getting a little bit of a dive on, before, taking a deep dive on before getting pregnant. Of course, when it comes to fertility testing or understanding, am I fertile? That's a tricky one because
hmm,
the ultimate test of whether you're fertile is trying to get pregnant.
yeah,
So you can't do that ahead of time. That's when you're ready for go. So, but I think sometimes there's some initial testing that we can do just to sort of look at, are you having regular cycles? Do we think you're ovulating regularly? What is your age? That's something that patients can benefit from being counseled around, in terms of where they are in that sort of trajectory.
Yeah.
Are they at an age where maybe it makes sense to take a more accelerated approach to their goals, or
Yeah.
are they at an age where they have the benefit of time? So that's a very individual piece.
Yeah. Yeah. No, I appreciate that perspective. And I really do think that there is something so empowering about that preconception visit. I think there are those patients who are coming in who already have a bunch of questions on their mind, but then there's also some patients who are coming in who would be like, I just never thought about anything else besides birth control. And they just really
Mm.
are eager and hungry for information and for help. And so I really think of our role as clinicians to use that appointment as a chance to yeah, I'm going to use your term a lot now, to really help these patients optimize themselves. It's not just simply like just explaining, the menstrual cycle and how conception works, but also just thinking about, hey, these are the other things that are going to help you be either, the healthier version of yourself or potentially have a healthier pregnancy. I really like that reframe. Rachel, as we wrap things up, what were some of the biggest wins or surprises when you developed Allara in terms of patient needs or outcomes or stories? What were
Mhm.
the things you saw the need, you felt it personally, you saw that Reddit was not the place to go for most, right? So you knew that you were building something big and powerful, but what was some of the things, one big thing that maybe surprised you the most?
Yeah, I think so. It's interesting. When I started Alara, we actually were just a PCOS platform. We just focused on
Yeah.
PCOS. And what was really surprising to me was how quickly we had women who didn't have PCOS either just straight signing up or emailing us saying, okay, I don't have PCOS, I have endometriosis or I have hypothyroidism. But what you're describing is exactly what I'm looking for and can't find. And can I just like hack the system and do it anyway? And the amount
Yeah.
of women who, really just whether their need was, again, endometriosis, hypothyroidism, metabolic syndrome, not sure what's going on in their body, like just the pain point felt so strong across such a wide variety of women that I think I actually didn't expect. It almost feels like every woman I know has some health struggle at some point in their life where they feel
Yeah.
like they don't know where to go or they feel confused. And so I think just like the wide spectrum of needs was really surprising to me. And I will say
Mhm.
like the other, I guess, nice surprise was just seeing the Alara babies that we've had. So we like the most exciting thing for us is when we hear a patient gets pregnant, especially naturally, especially patients who maybe spent the last 10 years thinking they couldn't get pregnant.
Yeah.
We've had a few of those and those always just really mean a lot.
Yeah. Oh, what a treasure. No, I mean, I I I I think so much as a clinician when I hear you say that women were coming out of the woodwork saying, "Hey, like I need this type of care too." You both probably can tell like I have a bleeding heart and that I just assume I should fix everything. So I'm like, "Oh my God, those are patients who like have women's health providers who somehow still aren't meeting them where they are." But we've talked again and again and again throughout this past almost hour now that they're not meeting them where they are because 10, 20 minutes isn't sufficient, right? And that's
Yeah.
okay. I think part of this conversation is therapy for me. So thank you, ladies. Is
Yeah.
just acknowledging that, the healthcare system as it stands, the healthcare system that I feel privileged and honored to work within is just it's at capacity. It really
Yes.
truly
Yeah.
is. And so of course women are wanting and seeking more. What they're seeking is an adjunct, a synergy between what their women's health provider is still able to consistently provide and then some, right? Like that's the ideal. That's what
Mhm.
really
Yeah.
what it looks like to really
Yeah.
lift women up and put them back at the center again is making sure that they are fully resourced. And so I feel like I'm walking away from this conversation with new teammates, right? Like I feel
Yeah.
really good. Again, I know Heather, you and I already refer patients back and forth, but Rachel, you're part of my team too, girl. So
Yes.
welcome.
Yes.
Because that feels so good for me.
Yeah.
It feels so so right for those patients who I cared so deeply about. It's a beautiful synergy that exists. As we kind of close, I always love to end with like a positive message for those who are listening. So for the women out there with PCOS, endometriosis, or as you said, other medical conditions that make them feel like there's still kind of this void, this searching, what would be kind of one message that you'd want them to hear today?
Yeah, I think for me, a big message I'd love for people to take away is you're not alone. And I mean that both
Mm,
you're not the only person experiencing this. It's a very common thing that a lot of women are experiencing. And there's like a whole sisterhood out there of people like you. And also, you're not alone from a care perspective. There are so many providers out there, whether they're in person or through Allara, who want to get you to a better place, who want to get you good care. I think sometimes as a patient, when we've had a bad experience, we can feel like, oh, the medical system is just like not going to help me. There's no one out there going to help me. And there's so many providers out there who, like you said, whether or not they have the time, they want to get you help. They want to get you to the right place. And so you're also not alone in terms of being able to be helped by the medical system.
I love that. Heather, what about
Yeah.
for you?
Well, I think one sort of positive thing that I've taken away from this conversation that I think is just sort of inspiring to me is I think there are so many providers out there and individuals like Rachel who want to do the right thing for these
Hmm.
patients. And the system in many ways has maybe made that hard in the past. But I do think we're in a new day where we're figuring out better ways to meet these patients and figure out how we can really partner with them. And I do think it really is going to be this partnership between people on the ground like you who can do the surgery and can deliver the babies and be there in person with other, other resources that can maybe deliver the type of more ongoing kind of chronic condition care that might be also needed. And so I'm taking away that this partnership moving forward is hopefully going to really elevate care for the patients that, we're also passionate about.
Yeah, yeah, we're all in it together. We really, really are. Okay, and then lastly, but definitely not least, what's next for Alara? What's on the horizon? What are you both so excited about?
Oh
Let's
gosh.
hype it up.
Yeah. I mean, I'm excited about just how much we've grown and we're continuing to grow.
Mm,
And we launched our first national insurance contract this year. We're now live in all
yeah.
50 states. So really our goal is just to get access to high quality care to as many women as possible across the country. We also have a lot of really exciting work coming up in research that Heather is taking the lead on that I'm really excited about. We just published our first impact report and are publishing a few more next year. I think recognizing this dearth of research, we're really trying to get as much as we can out there, and just continuing to see, where are there unmet needs for women and how can we continue to add to our platform to help meet them.
Yeah.
Yeah, I'm excited about, bringing in even a broader multidisciplinary approach. That's something we're really working on. And then I think thinking about some patient groups that maybe we haven't met as much of their needs thus far. And one being maybe sort of the older patients, and we're seeing
Hmm.
more patients in their 40s and 50s with PCOS or perhaps with perimenopause symptoms. And I think we're really tackling that patient population as well and trying to figure out how we can really meet those needs. And then I'm also really passionate about finding ways to sort of tackle that sort of late teens, early 20s. We've been,
Mm,
thinking about sort of student health angles because I feel like that's a group that often really feels alone
yeah.
and is in especially with some of these conditions that maybe are affecting their weight or how they look. How does that impact your trajectory as a person if you're worrying
Yeah.
about that as a 20-year-old or a 22-year-old? So seeing how we can really get at this group early and so before they get frustrated and before they really feel like they're struggling, that to me is an exciting idea that I think Alara is well positioned to take on.
Yeah, yeah. How thoughtful. Well, I said it before. This is what I needed, ladies. So thank you. I'm coming off of a 24-hour shift, somehow magically more energized thanks to this conversation. It's truly beautiful. I think I feel honored to always be in the space of people who are just as passionate about women's health as I am. It gives me so much hope. I have so much faith in the future for us as women and for our patients. So brava. Thank you, Rachel. Thank you, Heather, for continuing to fight the good fight. And more importantly, thank you for this time. It's been such a wonderful conversation.
It's so great chatting with you. Thanks for having us.
Yeah. And thank you for all you do.
Yes.
Oh, thank you both. Really appreciate it. Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.